Welcome back to the Deep Dive. We're here to bring you the essential knowledge straight from the sources.
And today we're tackling a really crucial, maybe sometimes overlooked, period.
Absolutely. We're doing a deep dive into what happens right after childbirth. That whole recovery zone, sometimes called the fourth stage of labor, and everything that follows postpartum.
Right, the puerperium, clinically speaking. It's just a time of enormous change, physiologically, psychologically. Everything is recalibrating.
And the sources we're drawing from today, they're pretty high level, aren't they?
They are. We're essentially tapping into nursing education materials, specifically CNUR 303, which focuses on exactly this postpartum care. So it gives us, and you listening, a kind of shortcut.
A shortcut to understanding what healthcare providers, especially nurses, are zeroing in on for safety and recovery.
Precisely, because it's not just about the birth event, it's this complex, critical aftermath.
I think that's so important. So our mission today is pretty clear, right? We want to describe those rapid physical and emotional shifts happening.
Yeah, and understand why they happen, the etiologies behind them.
And then summarize the kinds of focused assessments nurses are doing constantly.
And finally, pull out the really crucial teaching points and the specific nursing actions, the interventions that help support the birthing person and really the whole family.
It's that holistic picture, from tiny cells breaking down to huge emotional adjustments.
Exactly. And we'll be highlighting that nursing vigilance throughout, how crucial it is to anticipate issues, prevent complications, and manage this whole transition safely.
Okay, let's kick things off with the main player here, the uterus. It's just done this incredible job, stretched amazingly.
Like nothing else, really.
And now it has to pull off another huge feat, basically reversing that whole process, shrinking back down. This is uterine involution. Right?
That's the term, involution. It's the process of the uterus returning to its non-pregnant state, and it starts immediately after the placenta is delivered.
And it's not just like deflating passively.
Oh, not at all. It's a very active metabolic process. There are really three things happening at once.
Three mechanisms. Okay, let's break those down. It sounds more involved than I might have thought.
It really is. First, you've got the immediate contraction of the uterine muscle fibers. This is absolutely critical.
Why so critical right away?
Hemorrhage control. Those contracting muscles clamp down on the blood vessels where the placenta was attached. It's like a built-in tourniquet, nature's way of stopping bleeding immediately.
Wow. Okay, a living tourniquet. That makes sense. So that's mechanism one. What about all the extra tissue built up over months?
Right. That leads to the second mechanism, catabolism. This is basically the body breaking down the excess muscle cells, the myometrial cells that grew during pregnancy.
So the uterus has all this extra bulk it doesn't need anymore.
Exactly. And the body just gets rid of it efficiently. Enzymes break down the cytoplasm into simpler components, and these get excreted, mostly in the urine.
The body's recycling itself, essentially.
Yeah, you can put it that way, yeah. And the third part is regeneration. The uterine lining, the epithelium, especially where the placenta detached, needs to heal and regrow. That's vital for future pregnancies, future health.
Okay, contraction, breakdown, regeneration. Got it. And nurses track this externally, right? There's a pretty predictable timeline.
Absolutely. The key marker is the fundus, the top of the uterus. You can feel it through the abdomen.
Where should it be?
Right after birth, it's usually right around the level of the belly button, the umbilicus, maybe slightly below.
Okay.
Then the key thing nurses track is its descent. It should drop by about 1 centimeter, roughly, a finger width, every single day.
1 centimeter a day.
Yeah. And by about day 9 or 10, it should have shrunk back down enough to be behind the pubic bone so you can't feel it abdominally anymore.
And if it's not following that path, if it feels higher or off to the side.
That's a red flag, a big one. It could mean the uterus isn't contracting properly. We call that uterine atony, or, very commonly, that the bladder is full and pushing it up. Either way, it needs immediate attention.
That daily check sounds absolutely vital then. Now, you mentioned contractions. If the uterus is contracting hard, that means pain, which brings us to after pains.
Yes, after pains. They're literally the sensation of that involution process happening.
And I've heard they can be worse for someone who's had babies before. Why is that? It seems a bit counterintuitive.
It does, doesn't it? You'd think a tighter first-time uterus might cramp more. But the sources point out something interesting. For first-time moms, nulliparous women, the uterus tends to maintain a pretty good, constant, firm tone. So the cramping is usually milder, more steady.
Okay.
But for multiparous women, those who've delivered before, their uterine muscle has been stretched more. It has a harder time holding that continuous contraction.
Ah, so it's like it gets tired and slackens off of it.
Sort of. It tends to relax intermittently, and then it has to contract really vigorously to clamp down again and also to expel clots or remaining debris. These stronger periodic contractions are felt as more intense after pains.
That makes sense. And are there other things that make them worse?
Definitely. If the uterus was really stretched out, like with a very large baby, or twins, or excess amniotic fluid, the after pains will be more intense because the uterus has more work to do.
And breastfeeding. I hear that connection often.
Yes, breastfeeding significantly intensifies them. When the baby suckles, it triggers the release of oxytocin from the mother's brain.
The same hormone that causes labor contractions.
Exactly. So natural oxytocin makes the uterus contract more forcefully during feeding. You also see this if the patient is getting pitocin, which is synthetic oxytocin, often given after birth to prevent bleeding. It also ramps up the after pains.
So what's the nursing role here? Just tell them it's normal.
Well, yes, explaining why it's happening is key. Letting them know it's a sign the uterus is doing its job is important reassurance. But also, proactive pain management is crucial. Offering appropriate pain medication, especially before breastfeeding if they anticipate the pain.
And the good news.
The good news is they usually settle down quite a bit within about 3 to 7 days.
Okay. Let's move on to lochia. That's the vaginal discharge after birth, right? The body cleaning house.
Precisely. Lochia represents the shedding of the uterine lining and the healing of the placental site. Nurses assess it constantly: amount, color, consistency, odor.
And it changes over time. There are stages.
Yes, 3 distinct stages that reflect the healing process. First is lochia rubra. Think R for red.
Okay, rubra is red.
Deep red. This lasts for the first 3 to 4 days postpartum. It's mostly blood, some decidual tissue, maybe a few small clots, which are usually okay.
Then it changes.
Then it transitions to lochia serosa. This starts around day 4. It's much paler, pinkish or brownish. It's composed of older blood, serum, white blood cells, leukocytes, and tissue debris.
How long does serosa last?
It can last quite a while, actually, typically up to 2 to 4 weeks postpartum for many women.
Wow, okay. And the final stage.
That's lochia alba. Think A for, well, almost absent color, or white-yellow. Alba means white. This is mostly leukocytes, mucus, epithelial cells. It usually starts around day 10 to 14, but can continue for up to 6, even 8 weeks postpartum in some cases. The total duration of lochia is often around 4 to 6 weeks overall.
Does having a C-section change how much lochia one has?
Generally, yes. Lochia tends to be less after a cesarean birth.
Why is that?
Because during the surgery, the surgeon often suctions out blood and fluid from the uterus and sometimes even wipes the uterine lining before closing the incision, so there's just less material to be expelled vaginally afterwards.
Okay. Now, something really important nurses teach about is that sudden gush of blood when someone stands up. That sounds terrifying.
It can be really frightening if you're not expecting it. We call it the ambulation gush. It's crucial patient teaching.
So what's happening there?
When the person is lying down or resting, lochia naturally pools in the vagina because it's relaxed. When they stand up, gravity causes all that pooled blood to flow out at once. It seems like a sudden hemorrhage, but it's usually just the accumulated discharge.
So the key is distinguishing that from actual heavy bleeding.
Exactly. Nurses need to teach them. A gush when you first get up is generally normal. What's not normal is continuous, heavy bleeding that keeps flowing or soaking pads very quickly.
Which leads us right into the most critical bleeding assessment. Spotting postpartum hemorrhage, PPH. What's the absolute non-negotiable warning sign nurses are looking for?
The big one is saturation. If a perineal pad becomes completely saturated with blood in 15 minutes or less, that's an emergency.
15 minutes, okay.
Or if the nurse sees blood actively pooling under the patient's buttocks on the bed pad, either of those demands immediate action.
What action?
First, assess the fundus. Is it firm or boggy? If it's boggy, start vigorous uterine massage immediately. Then, initiate other PPH protocols, IV fluids, medications, oxygen, and notify the primary healthcare provider stat. Time is absolutely critical in PPH.
And to get a better handle on blood loss than just looking, many places use QBL, right? Quantitative blood loss.
Yes, QBL is becoming the standard of care because visual estimation is notoriously inaccurate.
How does QBL work?
It's pretty straightforward but meticulous. You weigh everything that's soaked with blood, peri pads, underpads, chucks, towels, anything. Then you subtract the known dry weight of those items. What's left is the weight of the blood loss, and since 1 gram is roughly equal to 1 milliliter of blood, you get a much more accurate volume.
And how often is this done?
Our sources mention its use in settings like the Saskatchewan Health Authority, where it's typically done routinely for the first 6 hours postpartum, starting right after delivery and continuing on the postpartum unit. It helps catch excessive bleeding early, even if it's a slower, steadier trickle rather than a sudden gush.
Okay, really important for safety. Let's quickly touch on other parts of the reproductive tract. The cervix. It took a beating during birth.
It certainly did. Immediately after birth, it's very soft, often floppy, maybe bruised or have small lacerations. But it starts closing down remarkably fast.
How fast?
Within 2 to 3 days, it's usually narrowed down to about 2 to 3 centimeters dilated. By 1 week postpartum, it's typically closed down to about 1 centimeter. It never quite returns to the pinpoint opening of a pre-pregnancy cervix, though.
And the vagina.
Also stretched, obviously, maybe swollen or bruised.
Yeah.
The rugae, those folds inside the vagina, start to reappear around 3 to 4 weeks. But there's an important point here, especially for breastfeeding moms.
What's that?
Because of the hormonal shifts during lactation, specifically hyperlactin-suppressing estrogen, the vaginal lining, the mucosa, often remains quite thin, maybe a bit dry or atrophic. This continues until estrogen levels rise again when menstruation resumes.
Ah, so that can affect comfort, maybe intimacy later on.
Absolutely. It's something nurses need to include in their teaching about resuming sexual activity. We'll come back to that.
Okay. And lastly for this section, the perineum and pelvic floor. You mentioned a surprisingly long healing timeline.
Yes, the surface healing the skin, any small tears or an episiotomy that usually looks pretty good within 2 to 3 weeks, that's what the patient sees and feels most acutely.
But that's not the whole story.
No. The deeper tissues, the muscles, the connective tissue, that complete healing can take much longer, potentially 4 to 6 months. And restoring full pelvic floor muscle tone, that often takes at least 6 months of consistent effort.
Wow. 4 to 6 months for full tissue healing. That really puts the short hospital stay in perspective, doesn't it?
It certainly does. It highlights why ongoing support and education are so vital well beyond those first few days.
All right, let's shift gears now to the hands-on nursing care. Managing all those common postpartum discomforts. Let's start right back at the perineum and pelvic floor. What are the immediate nursing interventions?
Okay, so the focus is twofold. Immediate comfort for the soreness and swelling, and then setting the stage for that long-term muscle recovery.
So for immediate comfort, what's the standard toolkit?
Ice packs are number one, especially in the first 24 hours. They reduce swelling, numb the area, just provide significant relief.
Ice packs.
Then the peri bottle, a simple plastic squeeze bottle filled with warm water. The patient uses it to rinse the perineum after using the toilet instead of wiping with paper, which can be really irritating. It also helps dilute urine so it doesn't sting as much.
Essential. What else?
Witch hazel pads like tucks are often used. They have a cooling, soothing, anti-inflammatory effect, especially helpful if there are hemorrhoids.
Ah, yes, hemorrhoids.
Yeah.
Almost universal postpartum, it seems.
Very, very common. Anal varicosities, technically. They can be quite painful. So besides witch hazel, topical anesthetic sprays or creams might be used. Sitz baths, shallow, warm water baths can also be really soothing, especially after a bowel movement. Usually okay for vaginal deliveries.
And pain medication.
Absolutely. Nurses need to make sure appropriate analgesics are ordered and offered regularly, not just waiting for the patient to ask. And importantly, ensuring they are safe for lactation if the mother is breastfeeding.
Okay, that covers immediate comfort. What about starting that long-term pelvic floor recovery?
That starts with education. Gently introducing Kegel exercises as soon as the patient feels able. Just simple pelvic floor muscle contractions.
Kegels. Everyone hears about them.
They're foundational. But for patients who had more significant trauma, specifically 3rd or 4th degree lacerations that involve the anal sphincter, just doing Kegels might not be enough.
What then?
For those patients, nurses should really be advocating for and initiating a referral to a pelvic floor physiotherapist. Specialized therapy can make a huge difference in preventing long-term issues like incontinence or pelvic organ prolapse, given that 6-month recovery window we talked about.
Okay, really important distinction there. Moving up to the breast now, there's a huge hormonal shift happening. How does the body actually start producing milk?
It's all triggered by the delivery of the placenta. Suddenly, the high levels of estrogen and progesterone that maintain the pregnancy just plummet.
That drop is the signal.
It's the green light. It removes the inhibition on prolactin, the primary milk-making hormone, which is already present. Prolactin levels then surge.
And what does that initial surge produce?
Colostrum, that amazing liquid gold you hear about. It's thick, yellowish, incredibly rich in antibodies, proteins, and immune factors. It's exactly what the newborn needs in those first few days, usually present for about the first 3 days.
And then the milk comes in. That phrase is used a lot.
Right. That refers to lactogenesis tecum, the transition to mature milk production. This usually happens between 72 and 96 hours postpartum, so day 3 or 4.
What's the change?
The colostrum gradually transitions to a larger volume of milk that looks quite different, thinner, more bluish-white, almost like skim milk. And this is when the breasts often become noticeably fuller, heavier, warmer, sometimes quite firm.
Which leads directly to engorgement.
Mhm.
We need to be clear, it's not just milk filling up, is it?
No, that's a common misconception. Engorgement is more complex. Yes, there's rapidly increasing milk volume, but there's also a significant increase in blood flow and lymphatic fluid to the breast tissue. It's a vascular congestion as much as anything.
So that's why they feel so hard and tight.
Exactly. That congestion makes the breast tissue feel tense, swollen, sometimes even hard as a rock. And importantly, that tightness can actually flatten the nipple, making it really difficult for the baby to latch on properly.
Okay, so for the mother who is breastfeeding, what's the key nursing strategy to manage this? It sounds painful and problematic for feeding.
The absolute key is frequent and effective milk removal. The more the breasts are emptied, the better the relief.
So just feed the baby more often.
Yes, encourage frequent breastfeeding on demand, ensuring the baby has a good latch and is transferring milk well. If the baby isn't latching well, or if the mother needs extra relief, pumping might be necessary.
What about comfort measures?
Pain medication is important again. Lactation-safe options like ibuprofen or acetaminophen. Non-pharmacological things help too. Applying warm compresses or taking a warm shower just before feeding can help milk flow. Then, using old packs or ice packs between feedings can help reduce swelling and inflammation.
And if the nipple is too flat to latch?
The nurse needs to teach the mother techniques like reverse pressure softening, gently pressing around the areola to push swelling back, or hand expressing just a little bit of milk first to soften the nipple area so the baby can latch.
Okay, that's crucial for breastfeeding success. Now let's flip to the other side, the mother who is not breastfeeding. How do we manage engorgement then? The goal is completely different.
Completely opposite, really. The goal here is milk suppression. Engorgement still happens, usually around day 3 or 4, for the same reasons that vascular and lymphatic congestion. But since there's no milk removal, the body gets the signal to stop production. It usually resolves on its own within about 24 to 36 hours.
But it can be really uncomfortable in the meantime. So what's the nursing advice?
Strict non-stimulation is the mantra. Anything that removes milk or stimulates the nipples will just encourage more production.
So what does non-stimulation look like in practice?
Wear a well-fitting supportive bra continuously 24/7 for the first 5 to 7 days. This helps compress the breasts and reduce discomfort.
Okay, supportive bra. What else?
Avoid any kind of nipple stimulation. That means no pumping, no hand expressing, even accidentally. And crucially, avoid letting warm water run directly over the breasts in the shower, as warmth encourages letdown and flow.
So cold instead of heat.
Yes. Cold is the key here. Ice packs applied to the breasts maybe 15 to 20 minutes at a time, several times a day, can provide significant relief. Some women find chilled cabbage leaves placed inside the bra helpful too. They seem to have some anti-inflammatory properties and conform nicely to the breast shape.
Cabbage leaves.
Okay.
And pain meds.
Yes, simple analgesics like acetaminophen or ibuprofen are usually sufficient to manage the discomfort until the engorgement subsides naturally.
Got it. Very different approaches based on feeding choice. Let's shift focus now to the urinary system. You mentioned this is a big area of concern, linked even to bleeding risk.
Absolutely huge. The bladder is really vulnerable postpartum. Several things happen. The trauma of birth itself can reduce sensation. Anesthesia, like an epidural, definitely decreases the urge to void. And on top of that, the body starts a massive fluid shift diuresis, trying to get rid of all the extra fluid from pregnancy.
So decreased sensation plus lots of urine production.
It's a perfect storm for urinary retention. The patient might have a very full bladder, but not even feel the need to go.
And why is a full bladder so dangerous postpartum? You
Well,
linked it to PPH.
it's a mechanical issue. Think back to the uterus needing to contract firmly. A full bladder sits right in front of the uterus and physically pushes it upwards and often off to the side.
Like an obstacle?
Exactly. It prevents the uterine muscle fibers from clamping down effectively. The uterus can't get firm. It stays boggy or atonic. And an atonic uterus bleeds. A distended bladder is one of the most common and preventable causes of excessive postpartum bleeding.
So what's the nursing priority?
Constant vigilance. Assessing the bladder, frequently palpating it, looking for that telltale bulge above the pubic bone, sometimes using a bladder scanner, encouraging the patient to try and void every few hours, even if they don't feel the urge, measuring the amount voided to ensure they're emptying adequately.
If they can't void.
If they genuinely can't void or aren't emptying completely, an in and out catheterization might be necessary to empty the bladder and allow the uterus to contract properly. It's that important.
Okay, message received. Empty bladder equals safer uterus. What about the GI system? Things seem to slow down there too.
They definitely can hit the pause button. It's very common for the first bowel movement to be delayed by 2 or 3 days postpartum.
Why the delay?
Several factors. There's decreased muscle tone in the intestines from pregnancy hormones. Sometimes there was diarrhea during early labor that emptied things out. Dehydration from labor is common. Pain medication, especially opioids, can slow motility.
And fear.
Oh, absolutely. Fear of pain is a huge factor. If the patient has stitches from a tear or episiotomy or painful hemorrhoids, the thought of having a bowel movement can be terrifying. They might consciously or unconsciously hold back.
So what are the nursing interventions here?
Mostly supportive.
Primarily proactive and supportive, yes. Encouraging lots of fluids helps with bowel function and lactation. Increasing dietary fiber. Making sure stool softeners are available, often routinely prescribed, maybe even a mild laxative if needed.
Just making it easier and less scary to go.
Exactly. And the nurse also does a basic GI assessment, listening for bowel sounds to make sure the intestines are active, checking if the patient's passing gas, which is a really good sign that things are moving again, and asking about their appetite. Okay, let's wrap this section with the cardiovascular system. Huge changes there too. The body has extra blood volume during pregnancy.
Right, that hypervolemia, about 40–45% extra blood volume, it's protective. It means the body can handle the normal blood loss during birth, around 500 milliols for a vaginal birth, maybe up to 1,000 milliols for a C-section, without the mother becoming hemodynamically unstable.
But after birth, the body needs to get rid of that extra volume.
Yes, it needs to correct itself fairly quickly. This happens mainly through 2 routes. That massive diuresis we mentioned, lots of urine output in the first few days, and diaphoresis, sweating. Plus, the circulation that was going to the placenta is just gone, reducing the load.
But there's a lingering risk factor from all those pregnancy changes, isn't there? Clots.
Yes, the risk of blood clots remains elevated postpartum. Pregnancy is naturally a hypercoagulable state. The blood clots more easily. This is protective against hemorrhage during birth, but the downside is that those clotting factors stay high for about 2 to 3 weeks after delivery.
And combined with other factors.
Combined with potential vessel damage during birth and maybe decreased mobility in the first day or two, it significantly increases the risk of deep vein thrombosis, DVT clots in the legs, or even pulmonary embolism, PE.
So the nursing intervention is
Early and frequent ambulation. Getting the patient up and walking as soon as safely possible is key to promoting circulation and preventing clots. Plus, assessing the legs for any signs of DVT.
How are vital signs expected to change in response to all this?
It's interesting. Because the cardiac workload decreases after birth, it's actually quite common and normal to see a slightly lower heart rate, what we call bradycardia, maybe 50 to 70 beats per minute in the first 48 hours or so.
So a slower pulse can be okay.
Yes, mild bradycardia often is. But the flip side is crucial. Tachycardia, a heart rate over 100, is not normal postpartum.
What could tachycardia indicate?
It's a warning sign. The body might be compensating for something: excessive pain, high anxiety, dehydration, maybe an underlying infection, or, most critically, it could be an early sign of hemorrhage, even if the bleeding isn't obvious yet. Tachycardia always needs investigation.
And blood pressure.
Blood pressure should generally remain stable and consistent with the patient's baseline during pregnancy. A significant drop could indicate hemorrhage, while a significant rise could signal developing postpartum preeclampsia. Nurses monitor BP closely, along with pulse and temperature.
Okay, so imagine the scene. The patient is moving from the intensity of labor and delivery to the postpartum unit. There's a critical handoff of information between nurses. Our sources really emphasize how much detail needs to be communicated.
It's a massive data transfer, truly, and it has to be accurate and complete because the postpartum nurse is taking over care and needs the full picture to anticipate risks and plan appropriately.
So what are the absolute must-haves in that report, starting with history?
You need the essential obstetrical background: patient's age, gravidipara, how many pregnancies, how many births, were they group B strep positive, what's their Rh blood type, are they immune to rubella? These immediately flag potential needs like antibiotics for the baby, Rogem for the mom, or a rubella vaccine.
Okay, baseline health info, then the birth story itself.
Absolutely. What kind of anesthesia did they have? Epidural, spinal, general? How long was the labor? Was it really fast or really long and difficult? What kind of delivery, vaginal or C-section? If vaginal, were there tears, episiotomy, what degree? Forceps, vacuum. All these details inform pain management, infection risk, mobility limitations.
Makes sense. And then their immediate status right before transfer.
Crucial. What was the last assessment of the phenostas? Where is it? Is it firm? How much lochia? And what does it look like? Is the bladder empty? What does the perineum look like? Swelling, bruising, sutures intact?
And you can't forget the other new arrival.
Never. Baby's details are key. Sex, weight, exact time of birth. How is the baby feeding breast, bottle, any issues so far? APGAR scores. And importantly, the nurse's initial observations about how the parents are interacting with the baby. Are they bonding? Any concerns?
Wow, it's a lot. But you can see how each piece helps the next nurse provide safe, individualized care.
Exactly. It allows them to move from just general postpartum care to really focusing on that specific patient's potential risks and needs.
Okay, let's dive into those risks. What are the major abnormal assessment findings, the red flags that signal something serious might be developing? Let's start with fever.
A temperature over 38 degrees Celsius or 100.4 Fahrenheit after the first 24 hours postpartum is considered a potential puerperal infection until proven otherwise. The first 24 hours might see a slight elevation due to dehydration or exertion, but after that, fever needs investigation.
How does the nurse investigate?
Systematically, where is the infection likely coming from? The fever comes with chills, pelvic pain, and maybe foul-smelling lochia. You suspect a uterine infection, endometritis. If there's localized redness, warmth, swelling, and pain in one breast, you think mastitis. If there's burning pain with urination and frequency, suspect a urinary tract infection, UTI. If there's redness, pus, or increasing pain around a C-section incision or perineal repair, that points to a wound infection. You have to look at the whole picture.
Got it. What about changes in lochia that signal trouble, specifically secondary hemorrhage?
Two key things to watch for. First, the amount. As we said, saturating a pad in less than an hour is excessive bleeding, suggesting active hemorrhage.
Okay, rate of bleeding.
Second is the pattern or trajectory. Let's say the lochia had already lightened up, maybe it was pinkish-brown, serosa. If it suddenly reverts back to bright red, heavy flow, rubra, that's a major warning sign.
What does that usually mean?
It often indicates secondary PPH, which can happen days or even weeks later. It's frequently caused by retained placental fragments that are preventing the uterus from staying contracted, or sometimes subinvolution, where the uterus just isn't shrinking down properly. Also, any foul or really putrid odor to the lochia is a strong sign of infection, like endometritis.
Okay. Headaches and vision changes, sometimes dismissed as just being tired, but potentially very serious.
Absolutely cannot be dismissed. A severe, persistent headache, especially if accompanied by blurred vision, seeing spots, or flashing lights, needs immediate evaluation.
What could it be?
The big concern is postpartum preeclampsia. It's critical for everyone to know that preeclampsia, with its high blood pressure and potential organ involvement, can develop after the baby is born, even if the mother's blood pressure was normal throughout pregnancy and labor.
So look for high BP plus headache vision changes.
Yes. And other signs like sudden severe swelling or pain in the upper abdomen, especially the right upper quadrant or epigastric area, that can indicate liver involvement, which is serious.
And there's another type of headache to consider, related to anesthesia.
Right. If the patient had an epidural or spinal, they could develop a post-dural puncture headache, or PDPH. This is caused by a small leak of cerebrospinal fluid.
How do you tell the difference?
The key feature of a PDPH is its positional nature. It's typically a severe headache that gets much worse when the person sits or stands up and dramatically improves or resolves completely when they lie flat. That positional aspect is the classic sign distinguishing it from preeclampsia headaches, which usually don't change much with position. Nursing assessment of this characteristic is vital.
Okay, good distinction. Now back to clots. We know the risk is higher. What are the specific signs nurses look for regarding DVT or PE?
For a deep vein thrombosis DVT, usually in the leg, the nurse is looking for unilateral signs, meaning just on one side. Things like calf pain or tenderness, warmth, redness, or noticeable swelling in one leg compared to the other. Checking for symmetry is key.
And if a clot travels. Pulmonary embolism.
A PE is a life-threatening emergency. The signs come on suddenly: acute shortness of breath, sharp chest pain, especially with breathing, a rapid heart rate, rapid breathing tachypnea, maybe a drop in oxygen saturation, feeling of impending doom. Any of those symptoms require an immediate emergency response. It's why nurses push for that early ambulation prevention is key.
Absolutely. And lastly, urinary issues again, difficulty voiding or pain.
We've covered why the inability to void or empty the bladder fully is a problem. It leads to retention and increases PPH risk. But burning pain during urination, or dysuria, is a classic sign of a UTI, which is also common postpartum, often related to catheterization during labor or birth trauma. Nurses track intake and output, ask about symptoms like burning, urgency, frequency, and may collect a urine sample if UTI is suspected.
Okay, so given this whole array of potential issues, how would you summarize the core nursing management approach during that immediate postpartum period? What are the main goals?
It really boils down to a framework of continuous focused assessment and proactive intervention. The absolute top priorities are maintaining good uterine tone to prevent hemorrhage, preventing or quickly addressing bladder distension to allow the uterus to contract and prevent UTIs, and preventing infection through good hygiene practices and monitoring.
Safety first.
Always. And then alongside that is promoting comfort and rest. Managing pain effectively, whether it's after pains, perineal pain, hemorrhoids, breast engorgement, or C-section incision pain, is crucial. Using both pharmacological and non-pharmacological methods tailored to whether the patient is breastfeeding.
And supporting their recovery.
Yes, assisting with ambulation, ensuring they're getting adequate nutrition and hydration, providing support and education for either establishing breastfeeding or comfortably suppressing lactation. Really, it's about creating an environment where the patient feels safe, supported, and can focus their energy on healing and bonding with their baby.
So far, we've focused heavily on the physical recovery, which is obviously huge. But the psychological adjustment is just as profound, isn't it? Let's start with something super common, the baby blues.
Incredibly common. Estimates suggest up to 80% of new mothers experience the postpartum blues. It's important to normalize this.
What does it typically look like?
It's characterized by emotional ups and downs, feeling weepy for no apparent reason, maybe more irritable, anxious, overwhelmed, having trouble sleeping even when the baby sleeps. Mood swings are common.
When does it usually happen?
It tends to emerge around day 3 to 5 postpartum, often coinciding with hormonal shifts and the milk coming in, plus the reality of sleep deprivation setting in. It typically peaks around day 5 to 7 and then resolves on its own, usually by day 10 or maybe up to 2 weeks.
And the key thing is that it's transient.
Exactly. It's mild, temporary, and self-limiting. The main nursing role here is education and reassurance. Letting the patient know this is normal, it's likely the hormones and adjustments, and it will pass. Providing support and encouraging rest are key.
But how do you know when it's not just the blues? When does it cross over into something more serious, like postpartum depression, PPD, or anxiety?
That's the critical distinction nurses need to screen for. The line is crossed when the symptoms are more severe, last longer, beyond 2 weeks, and start significantly interfering with the mother's ability to function or care for herself or baby.
What are those more severe symptoms?
Persistent feelings of sadness, hopelessness, worthlessness, or guilt. Intense anxiety or panic attacks. Loss of interest in things previously enjoyed. Significant changes in appetite or sleep beyond newborn demands. Difficulty bonding with the baby, feeling disconnected. And crucially, any thoughts of harming oneself or the baby, that's an emergency, requiring immediate intervention.
So duration, severity, and impact on function are the key differences.
Precisely. PPD and postpartum anxiety are clinical diagnoses that require professional treatment, often involving therapy, medication, or both. Screening and referral are vital nursing responsibilities.
Alongside managing mood, nurses play a big role in fostering that early connection between the parents and the baby, bonding and attachment.
Yes, they're really in a prime position to facilitate this. One of the most powerful ways is promoting immediate and sustained skin-to-skin contact right after birth.
That first hour.
Ideally, yes, that golden hour. Placing the naked baby directly on the mother's bare chest helps regulate the baby's temperature, heart rate, and breathing, and it floods the mother's body with oxytocin, that bonding hormone. It's incredibly beneficial for initiating breastfeeding, too. And partners can absolutely do skin-to-skin as well.
What kind of behaviors do nurses look for as signs of positive attachment forming?
We look for those early cues, parents gazing at the baby, talking to the baby in a high-pitched voice, calling the baby by name, gently touching or stroking the baby, often starting with just the fingertips on the hands and feet, then moving to embrace the whole baby, responding to the baby's cues like hunger or discomfort.
And conversely, what might be warning signs that attachment isn't progressing well?
Things like seeming indifferent to the baby, avoiding eye contact, referring to the baby impersonally, like it, expressing disappointment over the baby's sex or appearance, handling the baby roughly, or seeming very upset by normal baby things like spitting up or needing diaper changes, maybe refusing to participate in care.
But cultural context matters here.
Hugely important. Expressions of affection and parenting styles vary enormously across cultures. A nurse needs to be incredibly sensitive and avoid making assumptions based on their own cultural norms. Assessment must always be culturally appropriate and respectful.
Okay. As the hospital stay winds down, the focus shifts to discharge teaching, getting the family ready to manage at home. What are the essential self-care points?
Hygiene is top of the list for the mother's physical recovery, reinforcing the need for frequent peri-pad changes. Absolutely no tampons until cleared at the postpartum checkup, usually 6 weeks, due to infection risk. Keep using that peri bottle for rinsing after toileting. Wiping gently from front to back, always. Good hand hygiene.
What about rest and nutrition? Easy to say, hard to do with a newborn.
So true. But nurses need to stress the importance. Encourage naps whenever the baby sleeps. Remind breastfeeding mothers they need about 400–500 extra calories per day to support milk production. Nutrient-dense foods are key. Encourage adequate fluid intake. Gentle activity like walking is good, but advise waiting longer, maybe 4–6 weeks, especially after a C-section, before resuming strenuous exercise. Listen to your body.
Then there's the often awkward but essential topic, resuming intimacy and planning for contraception.
Yes, nurses need to bring this up proactively as part of routine discharge teaching. Many couples have questions but are hesitant to ask.
What's the general timeline guidance?
Generally, it's advised to wait until postpartum bleeding, Grokia has completely stopped, and any perineal tears or episiotomy have healed. This is usually around 3 to 6 weeks postpartum, but it varies greatly. The most important thing is for the couple to feel physically and emotionally ready.
And ovulation can return surprisingly quickly.
Very quickly, especially for mothers who are not breastfeeding exclusively. Ovulation can occur as soon as 1 month after birth, before the first period returns. So pregnancy is possible very early on.
Which makes contraception vital if another pregnancy isn't desired right away.
Absolutely. Nurses need to discuss contraceptive options, considering the mother's health history and feeding method. Some hormonal methods containing estrogen might not be recommended initially for breastfeeding mothers, as they could potentially impact milk supply, so progestin-only options or non-hormonal methods are often preferred.
And you mentioned potential vaginal dryness earlier due to breastfeeding hormones.
Yes, important to remind them that lubrication might be needed initially for comfort when they do resume intercourse. Open communication between partners is key.
Okay, shifting to future health planning. 2 specific interventions often happen right after birth: the rubella vaccine and RhoGAM.
Correct. If blood tests during pregnancy showed the mother is not immune to rubella, German measles, the MMR, measles, mumps, rubella vaccine, is strongly recommended postpartum.
Why
Because MMR is a live virus vaccine, it's not given during pregnancy. Postpartum is the ideal time to provide immunity for future pregnancies, as rubella infection during early pregnancy can cause serious birth defects.
Is there any special counseling needed with the MMR vaccine?
Yes, a critical piece. The patient must be advised to avoid becoming pregnant for at least 4 weeks, sometimes longer depending on local guidelines, maybe up to 3 months, after receiving the vaccine due to the theoretical risk to a developing fetus from the live virus.
Okay. And RhoGAM, who gets that and why?
RhoGAM, or Rh immune globulin, is given to mothers who are Rh negative themselves but have delivered an Rh positive baby.
What does it do?
During birth, or sometimes even during pregnancy, tiny amounts of the baby's Rh positive blood cells can enter the mother's Rh negative bloodstream. Her immune system sees these Rh positive cells as foreign and starts building antibodies against them. This usually doesn't affect the first Rh positive baby.
But it's a problem for future pregnancies.
Exactly. If she gets pregnant again with another Rh positive baby, those antibodies she developed can cross the placenta and attack the baby's red blood cells, causing serious anemia or other complications, hemolytic disease of the newborn. ROGAM prevents the mother's immune system from forming those antibodies in the first place. It essentially destroys any fetal Rh-positive cells in her system before her body mounts an immune response.
Does it require special consent?
Yes, because ROGAM is a blood product made from human plasma, informed consent is required. The nurse must explain the benefits, protecting future pregnancies, and any potential risks, and document this discussion thoroughly before administration, usually within 72 hours of birth.
Okay, bringing it all together as the family prepares to leave the hospital, the support shouldn't just stop at the door.
Absolutely not. Continuity of care is vital. Standard follow-up includes a checkup for the newborn, usually within the first week or two, and a comprehensive postpartum checkup for the birthing parent around 6 to 8 weeks after delivery.
Are home visits common?
They vary by region and healthcare system, but where available, postpartum home visits by public health nurses are incredibly valuable. They allow the nurse to assess the mother and baby in their own environment, check on feeding, answer questions, assess the home situation, screen for PPD, and reinforce teaching.
And research shows they help.
Yes, studies consistently show that good postpartum support, including home visits, can reduce costly outcomes like emergency room visits or hospital readmissions for both mother and baby. It's an investment in health.
And one final, absolutely critical teaching point before discharge: safe infant sleep.
Non-negotiable. Every parent needs clear, consistent messaging on safe sleep practices to reduce the risk of SIDS, sudden infant death syndrome, and other sleep-related deaths.
What are the core messages?
The ABCs are often used: alone, on their back in a crib, or bassinet or play yard. Alone means no pillows, blankets, stuffed animals, bumper pads, nothing else in the sleep space. Just a firm mattress with a fitted sheet.
Back to sleep.
Always place the baby on their back for every sleek naps in nighttime until they are 1 year old. If they roll over on their own, you don't have to flip them back, but always start them on their back.
What about room sharing versus bed sharing?
Room sharing, having the baby's separate sleep space in the parent's room, is recommended for at least the first 6 months, ideally the first year, as it's shown to reduce SID's risk. However, bed sharing, having the baby sleep in the parent's bed, is not recommended due to risks of suffocation, entrapment, and overheating.
And a smoke-free environment.
Absolutely essential. Exposure to smoke before and after birth significantly increases SID's risk. Maintaining a completely smoke-free home and car is vital for the baby's safety.
Wow. That was truly an exhaustive deep dive. We've covered everything from the uterus shrinking 1 centimeter a day to the intricate hormonal dance influencing mood and milk, right through to the critical safety checks and teaching nurses provide constantly.
It really highlights the sheer scope of recovery happening simultaneously on so many levels. Physical, hormonal, emotional, social, it's intense.
And hopefully, understanding this detailed process, which you now have a shortcut to through these nursing insights, makes it clear just how complex and demanding this postpartum period really is for families.
It demands specialized knowledge, continuous assessment, and compassionate support. It's far more than just recovering from birth.
So reflecting on everything we've discussed, especially that point about the perineum potentially taking 4 to 6 months to fully heal, here's a final thought for you to consider.
Okay.
If complete physical healing from the trauma of birth takes half a year or more for some tissues, what does that extended timeline suggest about the reality versus the expectations of postpartum recovery? Particularly when the typical hospital stay is now just a couple of days, leaving families to navigate this profound recovery largely on their own.
That's a powerful question to ponder. What does that disconnect tell us about the support systems we have, or perhaps lack?
Something to definitely think about. Thank you for joining us for this deep dive.
Thank you. We'll see you next time.